This program is brought to you by Emory University.
Thank you, everyone, for being here this morning for Friday morning Fellows Conference. As you can see, our speaker this morning is one of our first-year fellows that I recently learned, whose first name is pronounced Angelos, not Angelos. I've been calling him Angelos for several years, and he was very polite not to correct me, but I learned through back channels that his first name is actually pronounced Angelos. Angelos is a first-year fellow from Greece, and he went to med school in Greece at the University of Athens, if I recall, then came here to Emory for his residency. Now is a first-year fellow in our clinical track. As you can see, he's going to talk to us about lipid-lowering therapy. And so Dr. Angelos Karagiannis.
Thank you so much, Dr. Williams. It's an honor and pleasure to do this presentation today. Happy Friday, everyone. So the topic of today's presentation will be about LDL cholesterol. And it's a hot topic, right? There have been so many trials recently trying to see whether or not actual medications can decrease LDL cholesterol in the first place, and if whether these decrease in the LDL-C levels would have an impact on cardiovascular outcomes. And also question is, now that we can go low, how low should we go? And is it safe to go low? And is it still beneficial to go low? So all these questions will be eventually answered, hopefully, after this presentation. So I have nothing to disclose. So let's start with two theoretical cases. Case number one. So we have a 67-year-old male. He has a past medical history of CAD. He has had 2 episodes of MI in the past 2 years. Diabetes, hypertension, CKD. He's on maximum dose of atorvastatin. He's intolerant for some reason to ezetimibe. So pretty high risk high cardiovascular risk patient. So his lipid profile is total cholesterol of 135, HDL of 35, triglycerides 193, and an LDL-C of 61. And then the first theoretical question is, would you add a PCSK9 inhibitor on this high-risk patient with a maximum tolerated lipid-lowering regimen and an LDL-C of 61? Second case is that we have similar patient, high risk, 67-year-old guy, CAD, 2 episodes of MI in the past 2 years, that has been on atorvastatin and evolocumab. So his lipid profile comes back like that, with a total cholesterol of 105, HDL 35, triglycerides 22, and an LDL-C as low as 25. And then the question is this scary enough to stop, to stop the evolocumab? So why is this whole topic about LDL-C? Why LDL-C? We have plenty of lipids. We have IDL, we have VLDL, why LDL-C is the one that we are actually paying more attention? First of all, it has been proved that, serum LDL-C is a proven causative factor for developing CAD. And then it has been shown that there's actually a log linear correlation that higher LDL-C levels entails higher CAD risk. And conversely, we have shown that lowering serum LDL-C has been actually associated with a significant reduction in major cardiovascular events. And here's some seminal trials that have proved that. So we have the Jupiter trial that showed that rosuvastatin actually, 20 milligrams of rosuvastatin had an increase, had better cardiovascular outcomes. Same thing with higher intensity statin therapy in the Prove-It TIMI 22 trial, where atorvastatin actually proved to be more, has proved to have better outcomes compared to pravastatin. Then we had the Improve-It trial with ezetimibe on top of simvastatin that also improved cardiovascular outcomes. We had, the Fourier trial with the evolocumab PCSK9 inhibitor. And we also had the Odyssey outcomes trial with the alirocumab, and that also showed that it improved actually cardiovascular outcomes in patients after coronary syndrome. So, so naturally now we have the following questions. How low can we go? How do we have the possibility to go to levels that we've never had before? If we have this, is it safe to go to this level? And then do we find any benefit out of it? Is there any plateau where at specific LDL-C level that I would say no matter how lower we go, still we won't get any more cardiovascular benefit? So to answer the first question, how low can we go? First of all, so far we have a couple of agents that can help us decrease the LDL-C levels. One of them, the most known ones and the older ones in our, in our armamentarium is the statins, including the high intensity statins like rosuvastatin and atorvastatin. We also have ezetimibe, and we also have a very kind of recent addition to our medications, that these are the PCSK9 inhibitors, the evolocumab, also goes by the brand name Repatha, and the alirocumab with the Praluent, also known as Praluent. So in these aforementioned trials, we can see that actually there were plenty of patients that achieved pretty low LDL-C levels. So in the PROVE-TIMI-22 trial, we saw that there were 193 patients that actually achieved as low as less than 40 milligrams of per DL on LDL-C levels. Same thing in the Jupiter trial, we had 767 patients achieving that low levels. In IMPROVE trial, in some pooled data from 14 alirocumab trials, not though including the Odyssey outcomes trials. And then most of our actually a huge amount of patients in the Fourier trial, 8,000 and 2,669 respectively, achieved levels below from 20 to 50 and even below 20 milligrams per DL. So we can go low. We know that we can go low. Is it safe? So let's take some lessons from nature. So we have noticed that actually healthy human neonates have baseline low LDL-C levels. And there were even some studies that showed that these levels can go even lower than that, less than 30. And then of course, we can get huge information out of individuals with genetic conditions that have been associated with lifelong, very low LDL-C levels. And if these individuals who are in the long term exposed in extremely low LDL-C levels can be healthy, that's a positive sign that getting LDL-C levels down to even less than 30 or even less than that can be safe. So these are 6 conditions that actually have been associated with very low LDL-C levels. We have the PCSK9 loss of function mutations, we have the A-beta lipoproteinemia, the familial hypobeta lipoproteinemia, the familial combined hypolipidemia, the chylomicron retention disease, and the Smith-Lemli-Opitz syndrome. So interestingly, for some of them, we found that actually they confer a cardiovascular benefit. Here in the individuals with mutations, with loss of function mutations for PCSK9 gene, we found that they're healthy and they have even low rates of cardiovascular events. Same thing with individuals with the familial combined hypolipidemia. This is a disease that actually a condition that has a mutation in the angiopoietin 3 protein. And also they have been found to be healthy and have lower rates of cardiovascular events. And of course, some conditions can also come with some side effects, specifically in A-beta lipoproteinemia, we've seen significant deficiency in all these lipid soluble vitamins. And usually individuals demonstrate severe neurological manifestations, including ataxia, and even like they had like even specific ophthalmic disorders. We have also like in the familial hypobutyrolemia, we can see like liver cirrhosis, and then in the Smith-Lemli-Opitz syndrome, we've seen like pretty characteristic like facial features, some cardiac defects, and intellectual disability. However, interestingly, so far, it hasn't been proved that any of these side effects seen in these individuals are actually associated with lower LDL-C levels per se. And they have been rather shown that, if anything, like here, like in the orbital hypoproteinemia, these severe neurological manifestations are actually secondary to this significant deficiency of the vitamins, and then administration of vitamins can halt or even regress some of the symptoms. Same thing here, it is mostly because of some accumulation of toxic ApoB lipoproteins in the liver, and not the lower LDL-C levels that cause this liver cirrhosis. And as far as the Smith-Lemli-Opitz syndrome, it hasn't been fully like clarified why patients have these kind of comorbidities. However, it is speculated that it's mostly because of some toxic accumulation of some metabolites in the neurons rather than lower LDL-C levels. So that's why I'm mostly interested in patients with loss of function PCSK9 gene, and also in the angiopoietin 3 mutation, because these patients have a positive profile without any profound comorbidities. So as far as the PCSK9, so this is relatively new. I think it was just in the past 2 decades that actually our attention has been focused on this protein. So it can be produced pretty much from many tissues. It can even be produced, PCSK9 can be produced locally by endothelial cells, by macrophages. So there was a question even if PCSK9 is a player in the atherosclerotic plaque, and if it's also promotes inflammation there locally. But mostly PCSK9 is being produced also by liver cells, by hepatocytes, where most of the times it's actually secreted by the cells, and then it can go either in the systemic circulation or even autocrine action or even paracrine action, goes pretty much tight bindly to an LDL receptor. And then this tight binding doesn't allow the recycling of the LDL receptor, and therefore the LDL receptor is being destroyed. So pretty much higher PCSK9 levels or gain of function mutations of PCSK9 lead to lower LDLR levels, and subsequently to lower LDL clearance from the circulation and higher LDL-C levels in the circulation. So PCSK9 is bad. So we have to find a way to inhibit it pretty much.
Dr. Sperling just typed in, if you see everyone can see in the comments. We've started to treat patients with homozygous FH and refractory hyper, despite optimal therapy with evinacumab and ANGPTL3 monoclonal antibody administered by IV infusion monthly. So thank you for that, Dr.
Yeah, Dr. Sperling is always on top of everything, he up to date every time. That's wonderful. Yeah.
So let's talk. We just talked about PCSK9, and let's see what PCSK9 mutations can impact on individuals. So there was first I think in Montreal, Canada, Api Fadel found that there's some families there who had familial hypercholesterolemia, but didn't have the genetic the gene mutations that were known back at the time to cause that. So it was then discovered that there's this gene, the PCSK9 gene, where a gain of function actually mutation causes a phenotype consistent with autosomal dominant familial hypercholesterolemia. And these individuals would have early onset coronary artery disease. On the contrary, there were later found individuals with loss of function of PCSK9 gene. And these individuals had decreased cardiovascular events. They were completely healthy. And interestingly, there were even like individuals with compound homozygotes that they had lower levels, as low levels as like 14 of LDL-C. And they were completely healthy, no signs of like neurocognitive disorder. They were even like, they were fertile, like, and they did great. So we have those some potential concerns, like if we go that low to the LDL-C levels, were there any side effects? So the first question that most of people ask is that we know that like cholesterol is a major component of the membranes of the brain cells. So lower cholesterol levels, would that have any impact on any neurocognitive complications? Interestingly, though, it has been shown that the brain cholesterol regulation is mostly dependent upon local de novo cholesterol synthesis in the brain. And the circulating plasma cholesterol has no impact whatsoever on the synthesis and on this de novo synthesis cholesterol synthesis in the brain. So lower LDL-C levels are not necessarily associated with lower in the circulation, are not necessarily associated with lower LDL-C levels in the brain. There was this Osler trial with evolocumab that initially raised some concern about neurocognitive disorder in patients with being treated with evolocumab. However, a trial later called Ebbinghaus, like it was a sub-study of Fourier, actually showed that there are no neurocognitive complications in patients with evolocumab. So another concern would be if lower LDL-C actually has any impact on increasing the rates for hemorrhagic stroke. There's so much conflicting data out there. Like there are literally like 20 studies that support that actually lower LDL-C levels and statin use has been associated with small increase of incidence for hemorrhagic stroke. And there are 20 studies showing that there's no relationship whatsoever. It's interesting to see why we have this conflicting data. Is it just because we have like different, like, is it like because it could be just related to a specific agent like statins versus PCSK9 inhibitors? Because most of the studies have been actually conducted like in patients on statins. Or is this also like race related? Most of the studies actually have been on Asian population, and there is a little bit of more consistency in Asian population when it comes to hemorrhagic stroke and lower LDL-C levels. But this is yet to be clarified. Next concern is about new onset diabetes. So relatively recently, we found out that statin use has been actually associated with a modest increased incidence in new onset diabetes. Still, though, it is important to note that the cardiovascular benefit of statins is significantly more and bigger than the risk for new onset diabetes. And it's just that the statins that just moderately increase the A1C hemoglobin. And it's only after initiation, and actually A1C levels remain stable through time. It hasn't been exactly correlated, shown to be that the lower LDL-C levels with statins, the higher increase in A1C. There's some Mendelian study with Mendelian randomization that showed that, but I couldn't find anything like in the population out there that correlates LDL-C decrease with statins compared to and then the association with A1C levels. So as far as the PCSK9 inhibitors, so far, to in this short-term to mid-term kind of follow-up, there hasn't been shown any correlation between lowering LDL-C levels and increasing incidence of diabetes. So is this controversy a difference between agents? Like, is this just this new onset diabetes strictly related to statin use, or is it just because we haven't seen PCSK9 inhibitors in the long term, that we haven't monitored them in the long term, that we haven't still observed their impact on new onset diabetes? Next one, even though this is like of a less concern, is whether lower LDL-C levels have been associated with increased rate of cataracts. Mostly there was one secondary study actually. There was that pulled data from alirocumab trials, not the Odyssey outcome trial, that showed that there is like a higher rate of cataracts in patients with LDL-C levels than less than 25 milligrams per DL compared to patients with higher levels than 25. However, following studies, including like other sub-studies with patients with lower LDL-C levels and bigger studies like even the Odyssey outcomes, hasn't confirmed this concern. So this is a table actually with all these sub-studies from the aforementioned trials that specifically focused on patients that actually attained very low LDL-C levels. So we have here like the PROVE-TIMI 22 trial with atorvastatin, and they specifically looked at the patients that achieved like less than 40 milligrams per DL, and they looked at the benefits and potential adverse effects on these groups. So like mostly we have benefits. We can see like in patients with very low LDL-C levels, we could find like fewer major cardiac events, like in the PROVE-TIMI 22. We had, and also as well as like in the PROVE-FOURIER and all these alirocumab trials, still we could see like the patients with lower LDL-C levels, they had actually a more beneficial cardiovascular profile. As far as adverse effects, so there was this higher risk of physician-reported type 2 diabetes, hematuria, and hepatobiliary disorders and insomnia on this secondary study of Jupiter. However, this hasn't been confirmed by following trials. And then, as we discussed already, in this alirocumab pooled data, there was a concern for high rate of cataracts in patients with lower LDL-C levels. So even though, again, we still have some answers whether or not it's absolutely safe, so far we don't have any alarming evidence that actually lower LDL-C levels can cause, adverse effects. If anything, we have some supporting evidence that can cause actually can be causing cardiovascular benefits. However, is there a plateau on cardiovascular benefits that are achieved by lower LDL-C levels? So, and especially when it comes to levels like ultra low levels, even like below 30 milligrams per DL. So firstly, we had this GLACO study. They used intracoronary ultrasound, IVUS, and evaluated the effect of evolocumab on coronary atheroma volume. So it was found that patients on the evolocumab group, they actually had decreased total atheroma volume, and they even they were found to have like a atherosclerotic plaque regression. What is interesting is that this relationship was that between achieved LDL-C levels and percent atheroma volume regression was found to be as low as 20 milligrams DL. It's not like it stopped there. It's just they didn't do their study like to include even patients with lower levels than that. But it shows that the lower the LDL-C, statistically significant, it causes bigger plaque regression. So I would like to focus, out of all the other sub-studies that we discussed about, in this secondary sub-study from Giuliano of the FOURIER trial. So first of all, pretty briefly, Fourier trial was a pretty big trial, 27,000 patients, multi-centered, randomized controlled trial, double-blind. So it evaluated its evolocumab's impact on cardiovascular disease and clinical outcomes. So it was found that it actually causes like 15% of risk reduction in primary endpoints that consist of cardiovascular death, MI, revascularization, hospitalization for unstable angina, and ischemic stroke. So this is the sub-study that I would like to focus more. So what they did here is like they were more interested again in patients that achieved extremely low LDL-C levels, in patients of the Fourier trial that achieved these low levels. And they used all the patients available. There were like 27,000, but more, like 1,000 of them actually dropped out because they didn't have a good follow-up. So they, and then what they did is like, they had the same primary and secondary points with Fourier, and they tried to find whether or not these patients, like based on the LDL-C levels that they achieved, whether or not they had a better cardiovascular outcome. And they also were interested in their safety profile. The safety endpoints included all the concern, like including major concerns like cataract, hemorrhagic stroke, neurocognitive adverse events, new-onset diabetes mellitus, and even non-cardiovascular death. So here are the groups. So pretty much what they did is like at 4 weeks, they gather all the patients and they categorize them based on their LDL-C levels at 4 weeks. So these are the 5 groups. This group actually specifically is with patients, like 2,669 patients, that their LDL-C levels at 4 weeks were like less than 20 milligrams. This is less than 0.5 millimoles. It's like less than 20 milligrams. And there were also like 8,000 patients in the second group that they were having like LDL-C levels between 20 and 50 milligrams. So these are the baseline characteristics. We can see that there's some differences, like as far as the baseline, like smokers, diabetics actually were most likely to be on the lower LDL-C level groups. And so they were interested to see whether these groups will have a better, like whether they have a better outcomes and whether or not they were actually had any more adverse effects. So here is the primary endpoint, and here's the secondary endpoint, and both of them are based on the LDL-C levels. So these are the higher LDL-C levels, and these are the lowest. And we can see that the lower LDL-C levels, the lower the event rates. And what is most important here is that there is this monotonic correlation that doesn't seem to plateau. It is shown that even patients with lower and lower LDL-C levels, they will still have a cardiovascular benefit. And specifically, like the lowest level, like the lowest LDL-C group had like 10.3 event rate at 3 years compared to 15.5 on the highest level group. So this sub-study again showed this monotonic relationship between low LDL-C levels and risk for the primary and secondary endpoints. This benefit continues to extend in extremely low LDL-C levels, even less than 8 milligrams per DL without any plateau observed. As far as the risk and the safety events, they were actually, it has been shown that it was safe and there wasn't any any significance between different groups. Safe profile overall. So overall, we can say that extremely low levels of LDL-C, we have evidence that supports that they promote coronary plaque regression. We have evidence to support that lower LDL-C levels reduce the composite of cardiovascular death, myocardial infarction, ischemic stroke, coronary revascularization, and unstable angina. And there's a concern about whether or not this actually cause new-onset diabetes, hemorrhagic stroke, and/or cataract. in light of all this mounting evidence that the lower the better, without any major concern for side effects, both American and European guidelines updated their guidelines. So here we can say that in the 2018 American guidelines, actually in patients with clinical atherosclerotic cardiovascular disease who still have levels more than 70 milligrams per DL, and they are already on maximally tolerated statin therapy, it is reasonable to add ezetimibe. And then if in these patients already on highest statin and ezetimibe, and they still have higher than LDL-C levels of 70, then it is reasonable to add even a PCSK9 inhibitor. And this is like class 2A recommendations. Europeans are a little bit more aggressive. And what they said, like recently, they updated also their guidelines in 2019. They said that in very high-risk patients, and they define very high-risk patients as patients who have either documented atherosclerotic cardiovascular disease, diabetes with a target organ damage, severe kidney disease, and familial hypercholesterolemia with another major factor. So it's like it has like many patients actually would be into this category as very high-risk patients. So in these very high-risk patients, European guidelines LDL-C goal is less than 55. And to make things even more aggressive, in patients who experience a second vascular event within 2 years, they say that it is a class 2B recommendation that you can go as low as less than 40. So based on that, back in our case, we have this 67-year-old guy, high-risk patient. He had 2 MIs in the past 2 years, like maximum tolerated lipid-lowering agent, and with an LDL-C of 61. Would you add a PCSK9 inhibitor? Again, this might be aggressive. This is something that we can discuss later, but and it will depend on the cost, on the side effects, on the patient's decision as well. But it wouldn't be unreasonable 100% to get this even lower than that. And then the next case, exactly the same case, but this patient was already on evolocumab with a lipid, with an LDL-C of 25, and many people would be intimidated by these low LDL-C levels. In the question, would you stop the evolocumab? I could say with more certainty that no, an LDL-C level of 25 could be more beneficial and hasn't been shown to be any kind of adverse, especially on patients with PCSK9 inhibitors. So there are more medications to come. Like the one is the inclisiran. This is an siRNA inhibitor, PCSK9 inhibitor. There's currently this Orion 4 trial that investigates inclisiran's effect on cardiovascular outcome. There's this bempedoic acid. This is an ATP citrate lyase inhibitor. It is being investigated in the CLEAR outcomes. Again, bempedoic acid, whether or not it actually improves cardiovascular, it has any cardiovascular benefit. And interestingly, this bempedoic acid is actually it also like acts on the cholesterol synthesis cascade. However, it's like on an earlier step, and it hasn't been shown to have any kind of the myositis/myalgias that sometimes statins have been associated to, although so far its potency is lower compared to statin. And then we have, exactly as Dr. Sperling mentioned, the evinacumab. This is a pretty interesting medication. It's an angiopoietin-like 3 antibody. And along with lometapide and mipomersen, that all of them have been FDA approved for homozygous familial hypercholesterolemia. And it will be exciting to see if this NG, like evinacumab, will be also like investigated for even like in the more general population. As far as this lometapide and the mipomersen have been shown like to cause significant, like even liver cirrhosis. And it comes with no surprise because we remember that patients actually with genetic conditions with ApoB mutations, they actually come with liver cirrhosis as well. So as far as take-home points, so first of all, we know now that the LDL-C is a proven causative factor for atherosclerotic cardiovascular disease. We know that there are like several genetic conditions where individuals have been associated with lifelong very low LDL-C levels, and some of them have been found to be completely healthy. We know that we can reduce the LDL-C levels to an unprecedented extent. We know that in our clinical practice, we will encounter more and more patients with very low levels based on these new medications, based on these new guidelines. So it will be in our benefit to know how to deal with these low levels. And then as far as lower LDL-C levels and significant clinical adverse effects, long-term data is needed before we jump into conclusions. And the cardiovascular event reduction increases log linearly in association with lower LDL-C levels without any plateau observed. So overall, given the potential for cardiovascular benefit and safe profile of very low LDL-C levels, it's reasonable to aim to as low levels as possible, especially in specific high-risk populations. We should still, though, do an individualized approach. PCSK9 inhibitors are expensive, even though they're like their price actually cut in half compared to when they first, they were first were out there. Like I think right now, like they're around like 6,000 or 5,800 annual cost. They're still expensive, and also like in another individualized approach would be like concomitant comorbidities. Like, would you go aggressive on lipid lowering in patients with history of hemorrhagic stroke, and in patients that you won't expect them to be benefited enough, like they are lower cardiovascular risk. And then it would be reasonable if we do like a randomized controlled trial to compare efficacy and safety of very low LDL-C levels, even lower than 30, to current recommended targets, which are like less than 70 based on American guidelines and less than 55 on European guidelines. So overall, I would like to thank Dr. Sperling for his mentorship. Like, this whole presentation wouldn't be done without him. And I would like Dr. Williams that he offered me the possibility to be here at Emory, and I'm excited to be around. Last thing is that this picture is actually taken from Ikaria Island. This is an island which has almost one of the highest over-centurion population on Earth. And when I asked a local there what's their secret for living like hundreds, they said good food, good wine, good wife, and rest. That's what he said. Yeah, so that's it.
Probably some good genetics thrown in there too. Thanks, Angelos. Very good. Good review. And a lot of, interesting stuff to think and talk about. I guess, one thing that you didn't bring up, thought, was interesting, as when you talk about statins with patients, one thing obviously that comes up a lot is cognitive, the slight risk of increased risk of dementia, that sort of thing, that, there's been sort of a signal in some of the statin trials. And that was also, I remember, at least at some point, the very low LDL levels, there was at least like some theoretical risk of cognitive decline or neuro, I guess like diminished neurocognitive development in younger people with very low LDL, if I remember correctly. So any of that come up or as you're sort of looking through the data for this?
Yeah, that's a very good question. So there's some
I stole Elena's, by the way, I stole Elena's question. Elena brought this up too. What about dementia?
Yeah, that's a pretty good question. So again, there's some controversy, and as far as dementia, it's difficult to assess, especially with the newest medications like the PCSK9 inhibitors, because we don't have like enough long-term data. As far as statin and dementia, there were studies that showed that although they weren't the most highly like they weren't the most properly conducted, I would say. Like there were some observational studies that showed that, but there were some caveats on this side, so that's why I didn't include them. But this is definitely also something that we should be aware, and that's why, like in very older patients, again, what would be the benefit on starting someone on statin, and what would be the risk? But overall, I would say that I wasn't that much concerned specifically for statin use and low LDL-C levels in dementia. But definitely, it has to be, if there's any more better studies to come out there, like this is a very interesting topic as well.
Angelos, Stan Sherman. Any more about bempedoic acid? I mean, it's been approved and been approved with Zetia, and I find it, certainly a lot cheaper than evolocumab and such, and patients seem to be willing to take it because it's oral. Is there been any more data, or we got some more data coming on it?
Exactly. Yeah, it's a pretty promising medication. So there is, I think, as soon as the clear outcomes data comes out, and if that shows a benefit on cardiovascular outcome, bempedoic acid will be out there. Like a combination of bempedoic acid, ezetimibe, exactly as you said, and statin. It will be a very interesting regimen. I think that still I'm excited with PCSK9 inhibitors in terms of their potency. Like so far, they're the medications that have shown the bigger decrease in LDL-C, but their cost and their fact that they'll be administered subcutaneously might prohibit their extensive use. So bempedoic acid could be promising, and we're waiting for this clear outcomes trial to come out. And it has also a relatively pretty so far safe profile. I think the most one of concerning things is gout, but otherwise it seems to appear a safe drug overall.
Angelos, Andy Smith. So I guess one of the problems is as some would look at this data and get more and more aggressive with getting the LDL down, there's not an easy thing to follow. So, occasionally patients will come in with their calcium scores and want to get that repeated, but calcium scores, can get worse with more aggressive therapy. The other issue is, my understanding is there's a significant increase in side effects with atorvastatin when you go from 40 milligrams to 80 milligrams without that much improvement in your LDL. I don't know if you could comment on that or if Larry could, but in my practice, I often avoid 80 milligrams of atorvastatin.
Yeah, that's also a great question. Yeah, Dr. Sperling definitely will have more experience on that, and he'll be able to answer that. To my limited experience, and based also of what I heard around, is that as far as the side effects that you mentioned, on increasing atorvastatin from 40 to 80, most of them are associated with what we call myalgias, and but these most of the times are not sufficient enough to halt the increase from 40 to 80. As far as other side effects, I don't know specifically, but I would think that this is the mostly the thing that actually defers patients from getting higher and higher doses of statins. And one other thought that we had earlier was about the liver enzymes increase, which apparently right now we're not that concerned about increasing liver enzymes. We don't even need, to be honest, I think, to have a liver enzyme baseline even when we start statin. So this is not a problem anymore. But I can defer this question to Dr. Sperling if he has anything more to add.
Yes, certainly, Angelos. I was typing in the chat. There's something called the rule of sixes or sevens, which tells us that each time we double the statin dose from the primary effective dose, we only get a further 6 or 7% LDL lowering. And so there are diminishing returns. And as Dr. Smith said, there is evidence that statin-associated side effects and statin-associated muscle symptoms, and we were very intentional in the 2018 cholesterol guidelines. If you read all 125 pages, the term statin intolerance is found nowhere. We are trying to take that out of the lexicon because you brand people, and often then they're never tried again on another statin. So agree that in those having side effects, back off. And then for those at high risk, we often need combination therapies. It's finding the right statin for the right patient, and then lower appears to be better, especially in those at higher risk. And we don't want people to live in suffering with side effects, but we do want people to live longer and better and focus on preventable cardiovascular events.
All right. Well, if no other questions, again, thank you, Angelos. Wonderful talk and a very interesting discussion about this, some of these new therapies and new thoughts. Look forward to seeing everybody again next Friday morning for Fellows Conference.
The preceding program is copyrighted by Emory University.